Now I can hear you.
You can go ahead and present the case, Arif.
Okay. So, Bismillah ar-Rahman ar-Rahim. First of all, thank you very much, GIS, for inviting us, and wish you all the luck today, as it was beautiful also yesterday, as I heard. And allow me to introduce first a huge team that I have here. I have Dr. Wael Abu Shoqa on my right hand, Sister BG, Sister Shimnas Fedwa, technicians Walid, Ali, and Dr. Sabri, anesthetist behind us. We have quite a larger team than this, but before that, I would like to wish our leadership and people in United Arab Emirates about the 50th Jubilee this in 2nd December, and our congratulations. And besides, we don't forget our friends and families in Oman. Also, they had on the 18th of November their Jubilee. So congratulations to our friends in Oman. Now, without any more delay, we are really coming across a very interesting case here, and I'm sure there'll be a lot of hot discussion about it, and making more clear that even till this second, we are not very clear how we will land up at the end of this session. So that's in itself is going to be a hot way of thinking how PCI can be challenging. Dr. Weil, please go ahead.
Okay. May I have the presentation, please? So, good morning, everyone. Our case today is, next, please. Our patient today is a 47 years old male patient who is the only risk factors are smoking and dyslipidemia. He is he has depression on antidepressant. He was admitted to our hospital 5 days back with an STEMI. Next, please. His ECG showed no significant changes. Next, please. The echo, he had a good left ventricular ejection fraction with positive resting segmental motion abnormalities in the infralateral segments. Next, please. His labs were quite normal, except of the high troponin, which reached 9,000 high sensitivity troponin. Next, please. So, coronary angiography was done to the patient, and as we can see, in the RCA injections, the right posterolateral branch is totally occluded, which was treated as the culprit lesion at that time. Next, please. On the left system, the left main was normal. LCX small, it's a non-dominant artery, which is also normal. The LAD showed proximal tight stenosis and a bifurcation, Medina 1-1 stenosis. In two branches, one you might say is a diagonal and the other is the LAD, but it was really quite not satisfactory. Next view, please. In the PA cranial also, it will be more clear. That we were at this point to suspecting a dual LAD. So next, please. There is 6 types of dual LAD system. The first 3 types, 1, 2, and 3, the LAD arise from the left main, and 4, 5, and 6, the LAD arise from the right system. And there's a 7th type, which was recognized lately, where the short LAD arise from the left main before, before the bifurcation into LCXN. But let's talk about this. Our case today is type 1. It's really very rare. It's considered a rare anomaly that occur in 0.68% of individuals. Next, please. And this is a slide that discusses the classifications that we just went through. Next, please. So we went for a CT, multi-site CT angio that confirmed our suspicions that this is a dual LAD. And then Dr. Arif can discuss now. Go ahead, Dr. Arif.
Well, so far, I think we have enough to discuss. This kind of classification, we went through the literature. They have reached almost now 12 kind of classification or 12 types of anomalies. But this is the most common classification that Dr. Weil just raised up. And we can see that both are, we will talk about two things, the short LAD, long LAD. This terminology, we'll use it now. And the short usually is the one which is providing the septal perforators inside the interventricular sulcus. And the other one is providing the long LAD we will be talking about all the time is going to be the one which is the lateral from the septal. They are almost next to each other or above each other in somehow. So we will be having this nomenclature, so please pay attention when we talk, otherwise we'll be confused. So we will talk about two LADs, the lateral, the long, the shorter, with septal perforators. Next, please.
This is our strategy.
Right. So we will just going through and pro and contra, what to do, which strategy through the bifurcation, this case of which is more in favor of a little bit of decay crush or crushing or collot from the angle itself. So we thought before that, maybe we can spare ourselves the bifurcation by just doing the distal two parts of the both LADs. But we thought imaging will be the
You wanna
helping and deciding tool. Just Abu Khalid, just before I give you the microphone, so the situation was, strategy was initially just do the distal parts, which are tight, and then proximally to be assessed by FFR. But imaging will be decisive. So we will show you that after you come back to me now. I'll give you the microphone and then we'll show you the imaging. Please, Abdul Majid.
So I know you have a strategy in mind, but I thought we should get the panel here to share with us their how would they approach such a bifurcation. So I don't know, Tariq or Ziad.
Yes, if you don't mind, can you show us a better picture of that bifurcation? Because we really haven't seen it. From the slide, it wasn't clear.
Here,
Perhaps
please.
if you have one live now that
Live,
you can
please.
review
Give me
for
the
us.
PA cranial live, please. This one is fine. Thank you. Let it run, please. Dr. Ziad, if
So
you want me
now
to
we can
freeze it,
really
I'll freeze
appreciate
it.
and appreciate the, yeah.
So it's a dual LAD.
We can stop here.
So that's
Stop.
so
Yeah.
it's you went through a nice description of the dual LAD, so that it really brings up the point that this is a dual LAD and not a large bifurcating septal. So we see the septals from the more medial branch of that dual LAD. So you're going to be treating it as a bifurcation. Do you want us to do you want the panel to go through the different ways to address that, or do you want to give us your impression of how you
Okay.
want to
First,
approach it?
what I would love to hear from you, in case you see this angiographically, the way you see it, I can give you one more to show you one view to show the proximal LAD, so that you see the bifurcation itself. It didn't look that much. Can you go to one more shot, please? What caused us dilemma a little bit was, is it really necessary to go to that bifurcation? Because we thought initially the proximal sizing is quite mismatching with the two distal branches. It's almost 4 or 5. We estimated eyeballing, and then maybe the plaque is stable distal to that. FFR could be helpful. So if you look at this here, this view, the areocranial, we could say we could fix the short LAD with a short stent and the distal long LAD, another stent, and come out and leave the bifurcation for the time being since it's stable or by negative FFR. That was the discussion that I would like to hear your comment on, first of all, if you don't mind, Dr. Ghazal.
Okay, so let's, first of all, I want to bring up a question that if we have any question or concern in our mind that the lowermost branch is all a septal, then a fully lateral view will bring this into view, which means that if you have a fully lateral view, full lateral, this
Yes, we
is
took
a
it.
radial case, correct? Is this a
Yeah,
radial case?
go to
Yes,
lateral.
sir.
Yeah, so full lateral
Radial.
won't be
Back, back.
possible.
This one.
Oh, well, actually you do. And you see here, okay, so this is a nice demonstration of how this, what you're referring to as dual LAD, you see the overlap of those branches. And the septals are coming down straight while the other two branches are overlapping here, correct? So that's a nice demonstration. Now let's go back to the other view. Now that we've confirmed that the two are important branches, go back to the view that you had just now. Oh, that's
The
another nice
areocranial,
one
please. The
also.
areocranial, please. Yeah, this one.
So go back to the areocranial. Okay. So on that view, back to your point. If you can freeze it at a point where we can
There
see
was
the
a better
bifurcation.
view.
Yeah,
There
that's
was a
better.
better view. There was okay, stop.
Yeah.
Okay, stop here.
So
Sorry.
what you're referring, perfect. So what you're referring to is
Stop.
you have the bifurcation. Is it tight as a bifurcation? We know that the distal the distal segments beyond the bifurcations are both tight in both branches. So what you're saying is, why not just implant stents in the distal segments of the bifurcation and leave the bifurcation alone, guided by FFR, correct?
Absolutely.
That's the question you're posing. So
That's
how about if we let the panel, Khalid, you want to, or Tariq?
Arif, can you hear me?
yes, sir.
Yes. Yeah. I think, in my
No.
opinion, I think both vessels, as you said, this is dual LAD. I think both vessels are important. The challenging here, I think the angle is very narrow. But I think, in my opinion, I think you will not be happy if you leave this bifurcation. I think I would do both bifurcation technique up front and with a two stent. The risk here, I think we lose the septal branch. I think both are important. Both LAD is important. I think if you're going to go with your strategy, just tenting distal to the bifurcation and leave the bifurcation, I think the bifurcation is going to be significant. This is my opinion. You have to go back to the LAD, proximal LAD. So my strategy, I would do upfront two stent technique.
Thank you.
Khalid, would you keep it
25.
simple and avoid the angle, or would you extend and do a full bifurcation?
No, I think you have
Would
to
you
do
address
both.
those two lesions just
Yes.
after the bifurcation?
Yeah,
Only-
both. I think you go from both of them. This is my opinion.
Do we have any
Dr. Tariq?
intravascular imaging or not yet?
Okay. I will give you a help. I'll give you what you want. But I thought to get your help without imaging first, because for us it was really a bit, even by thinking, second scenario was to go provisionally and just put in the septal short LAD stent and the long LAD long stent covering, and then if needed we balloon, kissing balloon with a short LAD and finish. So we thought to simplify this as much as possible, but at the end I'll give you the OCT image which made us change our mind. And can we see the first OCT through the short LAD, please? Which means the one with supporting this septal perforators. So here we go distal. It is something like 225, 25, something like a relatively healthy segment. But then we see that kind of a tight lesion here, almost a catheter lumen managing that part. And this is more fibroatheroma. Little calcium, much, not much actually. It's inhomogeneous, but soft plaque. And then it goes, extends. This is the bifurcation. And then we go to the proximal, that LAD, which is the 1, 2, 3, 5, 3, 5, and then comes to the left main. Here comes the bifurcation with the circ and then the left main. So we have also a good landing zone here, distal to the left main. Go a little distal, please. Okay. Okay, more, 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 more. So up to here, we can see that we have good landing zone. So that was now in the short LAD. Any comment till now? Then we will move to the OCT of the long LAD.
So the segment just proximal to the bifurcation does not look tight, right? That's what you just demonstrated, correct? The segment just before the bifurcation.
It looks to be disease. I mean, the disease extends here. I cannot say it is stopping somewhere. This is really with thin cap, and you see, it's all disease. I'm afraid if I go really with a stent to there, I may create a dissection, and I land up again with a short stent to be crushed or whatever. So what Dr. Khalid said makes sense.
Good. So that answers your first question, which is you're not going to spare that segment proximal to the bifurcation. You're going to be stenting it.
Absolutely. It seems to be, it's involving.
Yeah. So even if it is FFR negative, since you are going to put a stent in that short LAD anyway, I think I would, as you're planning, extend it into the proximal to the bifurcation. So I think in my mind, this is, resolved. We're going to be treating it as a bifurcation. So now it leaves the question of, can you just stent, we're going to call them long and short as you are doing, long LAD, short LAD. Can you stent the long LAD distal to the bifurcation? In other words, not cover the ostium. Would that be appropriate? I tell you, in my mind, I would not do that because this is a long LAD. It's an important LAD. I'm going to be jailing it with another stent since we've just decided that by looking at the OCT. And I don't want to be putting a stent in the long LAD without covering the bifurcation and then jailing it with the main branch stent and possibly creating a narrowing in its ostium. So the narrowing is not good.
Okay? Right. So to make it simpler, Doctor, what we did in the short LAD, we thought we'll do imaging of the long LAD to see the ostial part, which you are emphasizing and worried about and having concern about getting compromised in the flow because of the size of this vessel. And we could not cross with a catheter easily, so we took a 1.5 balloon and pre-dilated gently that distal part, and then we were able to pass the OCT, and I'll show you the run now. Okay, so let us see the run to the long LAD, please. Yeah, just 1 minute, please, because we don't want to delay long, because the procedure might be a little complex. So maybe short comment, please, and then we will start. All right. I have to comment on this. Okay, so distal, we see that it's a diffusely diseased, same characteristics like the short LAD, mixed kind of fibroatheromatous changes, soft plaque mainly, not much calcium, and that we could also see in the ECG, in the CT, some cholesterol crystals were able to be visualized. And here we can see a little calcium. So it's a kind of inhomogeneous plaque, but certainly diffuse and severely diseased distal. And now we come to the ostium and that the bifurcation. So you see, there's no way of getting away with this. So it's extending to the proximal part that we have visualized earlier. Are you happy with this, Doctor?
So we'll let you carry on.
All right. So our plan is now to go for two-stent strategy, and we were thinking what to do, which strategy will be preferable since we decided to go for two-stent strategy. You can discuss this, Dr. Abdul Majid, but because we have a little concern, we have created some dissection in the long LAD. We were worried to, we thought Colot would be ideal. We have two large size, almost same size, but we were worried to lose this large long LAD and we don't want to rescue that. So in this case, we thought DK
Anyone who
Crush,
saw the provisional in this case.
center
No, I
please.
think
No.
a two
So
cent
everyone,
I think in your mind, as you're approaching this, you have to 20 to consider the side branch, right? Although importance, but as you I think this is approach and
One
then
test
pick
again.
your
Right.
Okay.
So I have a 225 non-compliant balloon 20 and I'll start pre-dilating this lesion in the short LAD. Preparing this lesion. So we see it's opening very nicely, so not much of resistance. Down, please. And I'll do a little bit of the
So Arif, you
osteo.
see you have a
Yes, again.
long LAD, the dissection.
Yes, we have seen it in the OCT. I maybe didn't point it out, but there was a small dissection. So we are a little bit concerned to lose that wire, and recrossing might be a problem for Colot. So safer, this is one of the indication when to go for DK crush. I mean, it's more challenging, but it is protecting us from any unpredictable situation for this large size long LAD. I don't know if the panelists have different opinion, but this is something that we don't want to go through from our team here. We thought this is safer.
So you're working now on the long LAD, correct? Dilating
No,
it.
short LAD. I pre-dilated with a
LAD.
225. And now I will place a 25 stent, 33, please. 2533, please, Sky Point.
So
And
you're going to place that distal to the bifurcation?
crossing over the large or long LAD. And we will do a pot. Sorry, I'm crushing it with a 3.5 balloon from that side. So we'll place a balloon.
So Arif, tell us your strategy. I'm just a little bit confused here.
Okay.
So you're dilated.
We're going
short
for
LAD.
DK crush. We'll go to DK crush, okay? So we will start now placing a stent into the short LAD and crush it with a 3.5 balloon and then recross and do the first kissing and then place a stent in the long LAD.
So
We
you're
can
treating the
discuss.
short LAD.
Yes. So I'll simplify it. I will treat this bifurcation as if I am doing left main bifurcation. The short LAD will be circumflex, the long LAD will be LAD. That is simplifying the situation. Okay?
Yes, that's good.
I think
Going in with the
Little Leo. I need the 3.5 balloon.
and then you're going to put the 3.5 balloon
Yes, please. At the bifurcation.
catheter.
It's a 7 French catheter, cylinder sheath.
Yeah. Yeah. Crucial in these type of
I agree. Make your life easier.
has limitation.
Make my life easier, actually.
Arif, by OCT
Yes.
handle
I can hear you, doctor.
the long. What's the diameter by OCT?
Which one?
The long
Diameter
LAD.
of. Yes, please. The long LED is 3. Yes, please.
Why is he using a 3.5?
Yes, please.
3.5 to crush it with if it's a
We'll take a shot here, please.
I think
We can say this is really good. What do you think?
Yeah,
Very good.
I would go with that.
Okay, let's go 246, please.
this is a
Yeah, stent.
balloon. This is a stent. Hmm? Okay.
Once, yeah, 246. Nominal, please. 10. Down, please. 14, please.
For the 7 French guide,
I think
Down, please.
really two big we're getting into, I would always use a 7 French. Provisional because it could turn into a two.
Wire. Okay.
Up
Dr.
to
Weil got.
12.
Yeah, it's
Okay,
a
let's go,
DK,
please.
DK.
Crush, please. 246, please. Save that one, please.
Were the wire planned, guys, or did you
12.
just
I don't know. You can guess what it was there. Down, please.
program after the stenting of the side branch to make
Again, please.
Okay,
One more
but,
time. 16,
Arif, would you pull
14,
wire out?
16. Down. Okay. Take that one out, please.
Arif, how
Can you?
far the stand? I said it, but I missed it. 14.
It went to 14. Can I have?
No.
Let's take
Can
a
you have
shot,
picture,
please.
Arif? We can see what.
1 second. The guide is
Can we
coming
take
up.
a
1
picture?
second. 1 second, please. 1 second, please. Open up, please. Oh, that was not good. Okay. Fine. Can I have wire, please? Go to LAO. Welcome to the real world.
Arif, would
Okay.
you,
Yeah, and
while
Yes.
he's rewiring,
I'm glad you did use a 3.5 balloon because it would technically easier to cross. You have a big loop
Yeah.
stent. While you're doing that, as an opinion, so you deployed your stent. I have to the nano crush technique.
Yes, please.
Go up to maybe 18 atmosphere or 20 atmospheres in order to make sure that the ostium, so-called ostium of that short LED is well dilated, and knowing that I'm safe into that 3.5, 3.75 proximal LED, I'm not going to dissect it. What does the
Yes,
panel
please.
think about that?
Can I have a
I
3,
think
please?
they actually
Guide.
did that step.
No.
After deploying the stent,
Hold
they
here,
pulled the
please.
balloon back and they
Okay,
did
we
the
can
side branch.
even.
Oh,
Here,
Yes,
yes.
I think I agree with you. I will do the same thing. I'll pull back and I'll do high pressure to make sure the passage. And I think I agree with Dr. Tariq was mentioned that I would not remove the wire unless have an angiogram, make sure there's no distal dissection. Then when I do the crush, I remove the wire.
so you would
Well,
dilate before you before you crush. That's right.
Sorry?
Dilate
Let me.
proximally.
Yeah.
Yeah, but I think Tariq said that they did that. I didn't
I
see them
did.
do
I
that.
did.
But,
I went back with a balloon, and I did up to 14, 16, approximately. So have more expansion.
16 proximally. Good,
Yeah. Yeah.
good.
Okay.
And
Go
make
back,
sure
please.
it's well dilated. And how about since while you're working, we can have a small discussion here. How about placement of that
Back, please.
so-called side branch mini crush? I mean, is it really important to be absolutely sure we protrude very little versus protruding 2 or 3 millimeter? It doesn't matter. And does it make a
please.
difference according
sec,
to the
one sec,
panel's
one sec.
experience in recrossing in terms of how much you've really crushed?
Yeah.
Khalid?
I think if I want to do the standard decay crush, it doesn't matter anymore. I can go back and crush it and rewiring. So we don't pay attention. And sometimes very difficult with the 2D to know how much you're protruding. So to make sure you're fully covered the carina, I think I'll make sure that I cover, because I know
Yes.
that I'm going to do the full decay crush.
Khalid, I mean, the angle, would you,
Yes.
would, would that make a difference in terms of how much protrusion you're going to have if you're having a more wider angle
Yes.
compared to
Yeah.
this one?
Sometimes, yeah, this is a very narrow angle, so sometimes you might need to protrude more, I think, to make sure you cover the angle. I think what you mentioned about the colloid is maybe a good technique here also to be done with this narrow angle. I don't know what's...
And that you would not worry
Yes.
if you're having a lot of protrusion that may
I have some spasm
give
here.
you a
We can go to 6.
I mean, if you're having a lot of protrusion, I mean, so if
Yes.
you're going beyond 2 or 3 millimeter of a
No, wait.
protrusion, that may give you a challenge going back. Despite, are you going to?
I have really massive.
I don't
getting
think
a
so,
challenge to-
but
But,
I think the message, you need to make sure you cover fully the carina, you not miss anything with the mini protrusion, I think.
Yes, please.
So there is the concept, in the last
Slowly.
couple of years of nano crush, whereby philosophically you're really having in the side branch the
Too much, I
outer
cannot.
edge
Yeah.
covered with a stent and
can
the lower
change the
edge
section.
not necessarily covered with stent.
Yes.
And you would be using for that purpose a thin
I have
strut
some issue with the
to make it
spasm,
fully
actually.
nano,
Severe
which
spasm.
is 60 microns, for example.
Yes, please.
Do you have any comment on that, creating a carina with minimal
Yes.
stent overlap?
Can I have a wire,
What do
please?
you
Run
think?
through wire.
Well, I heard about this nano, but I think, to be honest, practically, it would be very difficult to know it from angiogram with using
It would
the
be better.
nano
Yes.
strut technique. So honestly,
Okay. Let's
practically it would be very
Because
difficult.
you risk missing
Yes,
Hold
the
the
carina.
ostium a little bit.
Yes, that's the backdraw of it, I think. And the concern usually that you have too much strut overlap. But I didn't think with the decay crush, with double kissing and with optimization, I think, and if you use imaging, I think the risk of restenosis will be lower now.
Tariq, what do you think?
I'm a big fan of the classic DK Crush, and it's worked well for me. I worry about narrow angles to miss the carina if you're going really nano. I'm okay with overlapping, extending the side branch stent about 2 millimeters into the main vessel to make sure that it's all covered, and when I cross back again, I don't mangle the ostium of the stent.
Abdul Majid, what do you think?
Verapamil,
With the
verapamil.
nano technique.
Sorry, I was going to ask you, Ziad, you had a concern about the balloon size that Dr. Arif used to crush with. Can you comment on this?
Yes, well,
on the size of the balloon that you would use. You use a ratio of 1 to 1.
Yes, so Arif decided by OCT that this is a 3 millimeter vessel, the long one. So he's going to put a 3 millimeter stent.
Yes.
But then what I realized, he used the 3.5 but a short one, because the proximal part is at least a 3.75. So I think it's safe to do that. And that even, I think it's safe to do that. Short, big, fat, so that to make sure that you're really crushing that part of the stent, which is now protruding into the proximal part, which is a 3.5 plus.
Yes, please.
So you're going to use the proximal part as a reference to size your balloon.
Yes.
if you extend into the
Yes.
distal to the distal segment
Right.
to avoid dissection. Big
Yes.
balloon, but a short one.
Gentle pace.
And I don't think also he went to the just
To
he
the
went
side.
to the just the bifurcation.
Okay.
So he's back there.
We have to face a lot of spasm and test.
Yeah, especially now that because you're
Test.
even
Can I
more
have a run through wire, please?
When we inject, we are in
Okay.
inside.
when you
There you go.
have spasm.
You're in.
There you go.
Fixing the patient is important
Okay. Wire, please.
in spasm, but also the size is the radial. But he's a young guy.
We exchange actually to 6 French to overcome that kind of spasm.
Crush with 6 French, which will easily side. You can actually do 2 stents within a 6 French, but you have to before you advance the other one because the 2 stents are going to be tight.
This is which wire?
But 6 French is done
This
very
is
well.
run through.
Okay. PA cranial, please.
And the curve is a 4.
It's a 3. Okay. We are back to the short LED. Now let's have another wire, please.
Before wiring, we see what's happening. I
Yeah.
think
Okay.
he's having chest pain.
No. Patient's fine.
Where's the wire?
All right.
Run through.
Second wire, please.
And the flow is okay.
And there is the vessel.
And
Can I have,
Some
please?
crushed,
nitro.
Stent
There's
very
ST
nicely.
elevation in the inferior.
Sorry?
not only
There's
because
ST
it's a
elevation in
straight
the
segment,
inferior.
because we have a very
Those ST elevations were there before, or
Yeah. No,
No. We have to see.
it's inferior.
So we're not worried about the LED
Yes, please.
but
difficulty
he just took a
engaging.
picture
Yes.
and it's not.
1 second, please.
You know, we've had this issue before when you have in the root not intending.
Yes.
Just discomfort.
So you worry about us.
Let's see exercise.
Yes, please.
no pain?
Torque, please. Can you go to a little bit REO cranial?
From Jordan.
I think this is LCX. LCX.
Busy wiring.
Very busy wire.
Not
But
gonna-
Yes, please.
It's
You were
LCX.
sitting
1
at
second,
the bottom
please.
of the left main while you were, and you're not seeing where it's coming
Yes.
from more.
Yes, please.
I would just do a PA codal, a
Yes,
spide.
please.
Okay.
3.
Yeah,
Arif, does the patient have any?
No.
check the RCA.
Check the RCA.
I will do that, but I have to stabilize
Check
this
the
side
RCA.
also. Can I have,
Problem is that he has a
let's have a spider, please.
right now, so
So let's have a spider, please.
That was sent.
Can I have spider
So,
view
Arif,
just to
the
see
patient
sir?
has
You know, let him manage the
So circ is fine,
left main looks okay.
and left main looks okay. So now we have his elevation in the right. I don't know why, but he had a recent non-STEMI there, stent placed. So either we go to another guide from the femoral sheath and check the right. Can I have
Need
needle,
chest
please?
pain, Arif?
He has a little chest pain. Yeah. So I'll go to the femoral and have a look what's going on the left to right
Question
side.
to the
Can I have local anesthesia, please? Because
coagulation, anticoagulation here.
yeah, we have. Yeah.
Finish this one.
What if we place here? I cannot. If I place here, let me just have a look what's going on the right side because I have.
Khalid, let's skip the
But I want to know, Arif,
Yeah,
No chest pain.
she has chest pain. He has chest pain. And we have done 4
Because
days ago
inferior ST
stenting.
changes
It must be
product.
the right. It
Yeah,
must be the right.
yeah, but we have to check ACT, please. Yeah, give me a
with guiding
syringe, please.
catheters and having to rotate in the aortic root. Sometimes I've seen the into the right coronary artery.
Or the other thing is while you're
7 French, please.
time the catheter went to the RCA and
7,
ostial dissection to the
6.
RCA. So now we have to
Possible.
check, I think, to RCA
We
also.
have to check immediately the RCA. And temporary
Yes.
pacemaker standby, please. Okay, flush,
So
please.
he's going femoral and he will look at it. Let's just watch what.
Right guide, please.
You're going femoral, Arif, huh?
Yes, yes. No time to waste here.
Let
have
us
to
keep him
see.
focused on the case. He's going to be
Okay,
the right.
flushed already?
Yes, just a moment.
Back, please. Go. Show, please. And run through wire standby, please. Connection, please.
Fortunately, the
Why couldn't it?
images are blurred now.
So in terms of anticoagulation in such a
We'll flush some fluid, please, yeah?
how would that change?
That's one of the things I'll make sure that, because he has a recent stint in the RCA, I think also, to make sure he's anticoagulated very well during
Can
the
I have
procedure
syringe for
there.
ACT, please?
Ziad,
Syringe for
would you
ACT.
add anything to the anticoagulation regimen that the patient is having now?
Yeah, well, first, I think it's, I mean, I'm sure they've given their heparin or I'm not sure about bilirubin, whatever they use. The question now is immediately find out what's going on with the RCA. And I agree with Tariq. It's probably related to the
closure, please.
manipulation.
We need
Even though the
injection. We need to
manipulation,
inject.
as we saw, was very, conventional. Because right now, this is not the time, coincidentally, to have a stent thrombosis. I mean,
Contrast
obviously,
the
why
contrast,
now,
Dr. Harif.
right? That's not going to be the
Contrast, we use
case.
it manually.
Can I have
So most
needle?
likely,
Can I
it's
have
going to be some type of either
connection?
um,
Give me,
osteal,
give me the
let's say, dissection or embolization.
manual, just.
I mean,
please.
it's one of the two
Yes.
in the right coronary artery, because we have to tie it to the catheter manipulation, which we all do, and we do it in the same way Arif did it, nothing different. As
Small.
Tariq nicely pointed out,
Small.
he was the one who picked up on those
Okay.
ST segment
1
elevations.
second. Ready?
It could
Inject.
be related to, well,
PA cranium.
PDA.
no,
Yeah.
well, it looks like clot.
Just a little.
Where?
More contrast,
Comment
more
because we
contrast.
have hazy.
Yeah, we can't see.
We
very
have
well.
hazy images, so everything looks clotted. Everything
Ziad,
looks-
One
No
more shot,
dissection
please.
here,
PA cream.
There's
I
no
don't
dissection,
see.
no.
which is
Ready?
They're very well here. Can you comment on the RCA?
Nothing there actually. This could
Another-
Can
be.
you comment on the image that
There
you're
is
seeing?
there
Dr.
is
Arif,
there
because
is
you can't see it very
there is
well.
there is an occlusion of one of the branches in the upper posterolateral. Okay, can I have a small
Is
wire,
that the
please?
stented branch?
Yes, it is inside that.
You know, I may want to add here air embolization is number one on my list because it's getting, I'm not seeing the EKG, but I think the angiogram is getting better in the last.
Yeah.
Yeah.
Okay, there is a
Embolization
small
would be on
posterolateral
the top of my
branch
list.
which is occluded. Could be air, could be thrombus.
Give
I don't
flush.
know. Anything can be there.
Flush.
But most probably could be air embolization. I
Yes,
agree.
Yes.
I would wait. Are the STs getting better?
I think
Yeah.
so.
Is
So
the
we
chest
will work
pain
on the
getting
left
better?
side. I'll leave this guide here just to stand by.
Yes.
Nothing to be done there.
You can
Wait,
give-
wait, please.
I'm giving
We
it.
will
If the,
keep
if
it.
the blood pressure is okay, you can give nitro.
Yeah, we are doing
Nitrate.
that. We are doing so. So, I mean, let's go back to the left system. I think this will be coming back. We'll keep the guide here somewhere. Maybe
Okay. Let's have the stent.
Let us
Can
go
you,
because left is
Arif,
crucial.
can you describe?
Yeah, tell me.
3 or 4.
PA cranial, please. Okay.
Guys, please describe to us the, the
And we
status
have,
of the
Recording in
patient,
progress.
Sorry?
A balloon to
the
open
angiographic
the
timing
stent
on
with
the right.
I need a balloon,
uh,
please. A 2.25 balloon,
Can't hear.
non-compliant, long one.
we didn't open the stratus.
Recording in
ناخد واحدة 1.5
progress.
عشان نفتح الستارت 1.5 15.
All right. So now we will go back to our,
ECG is
since
settling
we,
down.
let me say, since we have no much the hemodynamic stability and we have seen the right coronary has no major dissection or thrombosis, I will go back to the most critical part
This is a short.
from,
This is a short LED.
no, this is a long,
There is a comment from Professor Mustafa here. 2B3A
Yeah.
here. Can you use 2B3A?
1.5.
Yeah.
No, we did not use 2B3A so far.
No, currently because you have a transient ST elevation. What do you want to use? A 2B3A?
Not
here?
necessary because it's a small branch. I don't want to increase the risk or anything now.
Especially
We
we
can
have-
wait a little bit. We give nitro. We will continue and then we'll give final shot if needed. We can start, but it's really a small vessel.
Actually, it's
and,
settling down now.
and it's settling down, as Dr. Weil is also pointing out.
Yeah.
So
The
we
ST
can go
elevation is
back.
improving.
And
Yeah.
I don't think any one of us know reason for ST elevation inferior. We didn't find anatomically anything. But I think maybe
No, we have a reason. There's an occlusion of the distal posterolateral branch.
There's cutoffs in the distal branches of the artery.
what
The distal BL branch.
Yeah, what caused it?
Likely air embolism or something.
From
Like
where? Air embolism from where?
Well,
During
during manipulation of the catheter.
Who's working on left main?
All right.
He was working with the cusp trying to
6,
engage.
8, 10, please, 12.
Hold on.
It's due to the medication itself. The anticoagulation is not enough.
So when he lost the guy, trying to re-engage,
Come, please,
manipulating
14.
in the aortic root sometimes can cause
Down, please. So
it
now
is-
I need
he's trying to get into that
2
system, but
balloon,
he's
please.
turning. Not
But with puffs, he's giving puffs while he's manipulating
May-
in the root.
And
maybe it's
two-
air, maybe
I
it's
mean, it's a
atheroma.
possibility.
Short
Maybe
one,
it's atheroma.
short one.
Yeah,
2
yeah.
balloon, please. 2 semi-compliant.
Thrombus or atheroma, absolutely.
So we have issue with the transmission. Can we have a better quality images?
Arif, we cannot see anything. The image is frozen.
Well, it's not with me. I don't know. So, people, can
do
you
have
check
it.
with the transmission, please?
But in summary,
Okay, 2
Dr.
balloon, please.
Yes, it's better now. Yeah.
Tariq, can you just summarize from what you saw and what we described what happened? I mean, it sounds like there's a distal occlusion of one of those vessels. We don't know. Is it air? Is it the thrombus? Do you have anything to add? Do you think an explanation to?
So I think
Come,
he,
please.
he found the explanation. He found the occluded branch. It was determined by the operators that it's too
Center,
small
please.
to do anything about. The patient is hemodynamically stable and the EKG is improving. So I think it's probably an embolic event. We can't speculate whether it's air, thrombus, or
2, 4,
atheroma,
6,
but
please.
regardless,
8,
that's
10.
that's not the issue right now.
12, 14.
Thanks. So the
Down,
ECG is settling. Obviously, the patient
I need a
is
2.5 non-compliant, 15. And
hemodynamically stable, and
3, please.
and
Again,
it doesn't
please.
look like there's any.
So now you're opening the struts of the crushed stent, correct?
Yes, please. 16, 18.
Yeah.
Down, please.
I personally always like to put a balloon, even though a balloon in the other branch, because
Can I have now
sometimes,
2 balloons, please?
depending on
3,
how much the stent is protruding,
3,
48.
some of
2.5
this crushed
non-compliant,
metal could push into
and a 3 semi-compliant with
branch.
the LED.
That is
the
true.
main vessel.
And I've always done the one balloon. It is called double crush technique, and this is the first crush of those. I've usually done one balloon until most recently I had a stent strut stick out in the main
Yes.
vessel, and I couldn't crush it. I couldn't pass
Yes.
the crushing stent, so I had to go back with a crush, double kissing balloon.
Yeah. That's why I always leave a balloon. I mean, you lose nothing by leaving a balloon there.
It's an extra step.
Yeah.
I have a comment. Can I add a comment here,
yeah.
please? I mean, that is really very wise, and we face this trouble sometimes protruding struts after doing this, opening the struts. In this case, I am a little bit disturbed because I have really to act faster a bit. Second, and
Yes, I
sometimes I
agree.
have resistance. sometimes, which is making more complex, you know. Just open the struts now. Sometimes it goes much easier. So with one second, please. The second balloon, please. So by having two balloons and six French and struggling, sometimes in this kind of scenario, an emergency case with this elevation and all that kind of thing, better not to go and waste much time with that now. I know it can save you a lot of time later on. In case I could not cross now, I may regret and say, oh, I should have done what you're saying. We do that usually, frankly said. It's not that we do this way every time. But in
So
this situation,
what you're doing now, you're going to do the first kiss, am I right?
yes, sir. I know I cross easily now.
What's the balloon size and the?
It's a
what's the balloon size
315,
and
315 in the long LED and a 25 non-compliant in the short LED. Okay, let's go with the short first. Just open up nicely. Go 2, 4, 6, 8, 10, 12, 14. I just open the struts and give a nice pressure. Down, please. Now we'll do a kissing just to 10, please. 6 together. 2,
So
4,
Arif wants
6.
to go just to 10. Is anybody used to go
6,
higher? I'm used
both
to
please,
going
yeah?
not more than 10 on both.
That's it. Thank you. Thank you.
No, both. When you do the kissing, I mean, I'm fine with 10 like he's doing, but does anybody like to go higher?
I got 10, 10, 12, 12, but not more than that. But isolately, I do high pressure here, high pressure alternatively, then simultaneously.
That's a good idea too.
100%. I agree with that, of course.
Yeah.
Okay, now I need a balloon, please. A 275 balloon for
The balloon,
pre-dilatation.
the size of the balloon you use for
30.
kissing would be the 1-to-1 ratio.
Yes, I use a 1-to-1 ratio, yes.
Yeah, reference to the distal vessel.
Reference to the, yeah. And the point is well taken. In the side branch, the first inflation in the side branch, you could do it.
Go back, please.
Oh, the wire came back out?
Yeah, that's the long LED wire came back.
Okay.
That's fine. We will find our way back. It's okay. Sometimes by having two balloons, it is getting sticky and you may have this kind of situation.
Yes.
Test, please. Test, please.
You're on an approximate, right? Yeah, there you go.
Test, please.
Take your time, Arif.
Take your time,
Okay.
All right.
Good.
Balloon,
Very
please.
nice.
So now it's time for the long stent, correct?
I will pre-dilate first.
Pre-dilate. Maybe pre-dilate with a long
If
balloon
we,
just to
yes, we have a
estimate the
30,
size.
275 30. And
Yeah.
besides,
so in the
we
meantime-
have seen in the CT there is a calcified lesion proximally. In the CT was obvious, and even in the OCT. So better to prepare and not to have a problem with the crossing of the stent.
Arif, we received the comment, now that you're done with the right, do you want to take one last picture of the right and take the guider out to make things less complicated for you?
I have
normalized.
ECG is normal, so I will not do that. I have much more important here to do now. So that
Okay.
is really for satisfying me and this feeling you comfortable, but this is more critical now.
How long
Test,
is this
please.
balloon?
30.
275.
2, 4, 6, please. 2, 4, 6, 8.
30.
10.
So the stent is going to be panel
48.
members 40.
I'll take 48. I'll take 48.
48, 3,
Down,
0,
please.
and then do a pot proximally.
Yes, sir.
You kiss and then you do a pot.
Again, please.
Okay. So balloon
Well,
size again, Arif?
12. It's a 30. 275, 30 non-compliant. Down, please.
Excellent.
4,
Take your
6, 8, 10, 12, 14.
Yeah.
Again, please. One more time. 14. Nice. Okay, it's opening nicely. Down, please. So let's have a 48. 348, please.
048.
We can
And then
reach up to
pot with it.
375 with a 4. 375, we can go with the 375, which is the maximum for that. Sky point for the 3. The other option is to take a short one, a 3, and then with the 3.5 from proximal. That is another option.
Long one is a good
That's
choice.
exactly
You don't
my
have the
strategy.
45?
Can you hold here, please? Sorry? We have 48. 3548 is too long for distal. It's not suitable.
3548 or 3048?
Yeah.
You lost the wire.
It's fine. It's fine. It's got pin tingled.
He has to recross anyway.
No, he has to pull the wire before deploying
Yes,
the LED,
yes,
the LED
yes.
stand.
He
Then
has
he has to
to-
recross.
he has
and
to
yes,
recross
right.
anyway, yes.
Okay, that's fine. That's fine.
No, we don't leave this wire.
1 second.
Okay.
All right. I got it. I got it. It's okay. All right. Anyway, we have to remove that wire anyway.
Yeah.
It wasn't intentionally, but I'm happy. All right. Take it out, please.
No,
All
no,
right,
it's
let me
okay
have the
because
stand.
you're gonna have
Take
to
your time.
recross, so.
Absolutely. We opened it anyway with 2.5 nicely. So I have no worry. All right. It's sometimes
you
when you
always-
have really tingled and little bit.
So you always pull the side branch wire before you deploy the second.
Absolutely,
Because you don't want the
absolutely.
wire trapped
To
between
be
two
jailed.
stent layers.
Yeah, or some people leave it just because if it closes, it gives you quote unquote a roadmap.
They don't like to leave it between two struts.
Yeah,
too
well,
little.
Stented. Austin,
I tell you one
I-
thing.
I remove it too, but all I'm saying is some people leave it as if exactly when you leave a wire in a side branch, right? If you're going to do provisional, you leave the wire in the side branch in case it closes. It's a roadmap for you. It's the same concept here, even if you've scented it,
So-
because
So-
something may happen, it may close.
So the concern is that you're now jailing the wire between two layers of metal.
Yes, it's not two layers; it's one layer because
So
it's a
this
mini
is
crush.
really impressive.
So
I
it's
thought
really
I
one
may
layer.
have a problem
There's metal on
with
the outside,
this,
there's metal on
but
the
the stent really didn't cause me
Size
much.
is
This
30 by 48.
test, please. So
So
this
this is a 3048 stent, right?
yeah, but the thing is really I'm happy that this didn't cause me much of trouble to deliver. Actually, this is the sky point what they are propagated for. Inject, please. That they have better pushability. I can go back a little bit. Let us have PA codal, please,
No,
to
I
see the
thi-
landing
think it
zone.
looks good
Proximal
here.
landing zone. I'll just take one more projection proximally. Test, please. Yeah, here looks fine
I
actually.
think you got a good position, yes.
Okay, let's go 246, please. 8, 10. And then I need 375 balloon, please. 15 or 12.
Just to confirm, this is a 3038.
Yes, yes.
3048.
Down, please.
Khalid, for when you're selecting this.
Can we stand
the
boost,
size of
please?
the
One
stent,
stand boost.
you consider the expandable diameter of the stent, you know, in terms of selection, would you select the stent over the other, considering the
375 balloon,
expansion
please.
of the stent?
Yeah. Now, I
Like
think
for such a-
majority of the stand you can expand it very well. I think the 3.0 you can go up to 45. So I don't think there's a problem now with the new generation stand for term selection.
It's only when we get to the real big sizes of
Let's take a shot
taking a
here, please.
3.5 to a 5.55, for example,
Right.
then we
The
need
PA
to
cranium,
have
please.
the company generate a chart that tells you what's the maximum you can go to without deforming the stent. But like Khalid said, in this situation,
One more
really, we're still within medium size vessels, so it's okay.
Look very nice.
Yes, looks nice.
So you'll do bot now, then rewire, then second kiss, huh?
Yes, we are going to pot first with the 375. And we can see that the two septal perforators, the large septals are still there. Hopefully we don't compromise them more. Though I have to do with this, otherwise I can't cross easily.
So now the recrossing, this philosophy of proximal or distal wire crossing. I mean, you know, and I heard Fajade one day say, it's really hard to know where you are,
246,
proximal or distal.
246, please.
Do you guys care about that much? Abdul Majid, for example, do you?
6,
To
8.
be honest, I mean, it's, I don't see
Yeah, thank you. No.
easily to predict where the
Yeah.
fire
Sion.
is going, you know. Using imaging sometimes may help, but I think it's very difficult to predict
Yes.
where the wire is.
And pot is, so obviously classically proximal for, I mean, classically for any bifurcation, you would want to cross distal, and for double kiss crush, you would want to cross proximal. But here, pot is very, very important. Maybe less important in this case because the so-called side branch is straight. It's coming down straight. So it's not going to really bother you much. But if the side branch is coming at an angle of 60, 70 degrees, I think pot is very important, and pot has to be done in a way which is really putting your distal marker at the distal edge of the carina. This way, recrossing is safer and better.
So well, I think, Ziad, in this patient, I think pot is very important because the vessel diameter approximately is very big. You don't want to go behind the
strut. That's a very good point. And in fact, that's why Arif used 375, even bigger than the first one he used. So that's very, very appropriate.
So Arif will let you carry on case.
Well, you know, just one comment. I heard one comment once from Colombo when he said, and everyone was laughing, but I think he's fully right. I mean, he said to the which struts you choose, he says, I'll be happy if I cross at all. So don't ask me at that moment which one. It's practical answer. It's a very practical answer. So I'm happy now I cross. If you tell me go check which strut you have crossed, I said I don't mind. I don't care which one is it because I have no data showing me any evidence of any clinical advantages. So frankly said,
we're coming to the end of the time of the session. Is there any comment before we leave you?
Well,
you did very well.
You can show the final result at 4 o'clock.
I'll give them one time. Well, I will.
What's the size of the balloon you're going to use for the second kiss now?
Show me the right, please. I just make sure that people are happy with the right because I have ECG is really normal. The guide is out somehow. I don't know where is it. 1 second. Maybe the people who want to see this, please. I will tell you my comment in a minute. Just final comment. Okay, 1 second, please. Yeah, ready?
Yeah.
Inject, please. Okay, it's back. All right. So we take this out, please. Watch, please. Yeah. Right. So now, I mean, this was a complex case. We will do now a pot, kissing a pot, and we saw the wire crossing easily through the strut. So I have nothing to worry about to cross my second balloon and do the same thing one more step. It will take me another 2 minutes. I think this situation revealed really how to manage step by step, changing your strategy, and you have to be prepared for the unpredictable situations. That was a very good example, and having a sea elevation in this, how to be calm and try to manage and understand the mechanism and prioritize your procedure steps. Second, changing the strategy is not something unusual in our daily practice. We should be flexible, having a team with you. We discussed with Dr. Weil. He suggested to change the guiding catheter from 7 to 6. That is something shows that teamwork has really very impact. You should listen to everyone in the room. Who is saying what? Because under such situation, you may be really not focused on something, but you are forgetting others. So my take-home message again, always listen to what's happening, be calm, and do your step-by-step what is you are doing on daily basis. That's the key issue. Thank you very much.
That was an excellent case.
Thank you, Dr.
Excellent case.
Nice demonstration of a DK crash and also of managing totally unpredictable event. Thank you so much. I don't know if there's any comment from the panel before we close.
I mean, I think like Arif said, this is, you know, we're all used to seeing complex bifurcation, live transmissions where everything goes well. This has been really a nicer demonstration than the ones I've seen in bifurcations because there was an unexpected complication that, as Arif said, he took care of it very diligently and meticulously. So it was nice to see this kind of nice to see how it evolved.
Excellent. One comment.
Excellent job and keeping calm under pressure and having 3 or 4 panelists talk to you while you're managing a patient with ST elevation. That was an excellent example of composure during a procedure. Excellent job, Arif.
Thank you. All the best.
take round. Thank you. Thank you, Khalid.
Yes, Arif, thank you. Excellent case, excellent demonstration. How do you handle a complication during the procedure? And you did it very well and with outstanding result, really, with this dual LAD. Thank you very much for
Thank
showing
you, sir.
this and sharing
Thank you
that.
all for your support and
Congratulations.
your
Was very
ideas
strong.
and suggestions. Thank you very much.